Hi, everyone, and welcome to MedEdge. I'm Marcus Grimm. This is a quick reminder. MedEdge is brought to you by Medtrics. Medtrics is the premier engagement platform for medical students, residents, faculty, and administrators, both UME and GME, and even veterinary and osteopathic as well. Learn more at medtrixlab.com or from my frequent co-host, Dr. Santosh Cherian. But not today. Tosh is taking care of those customers, and we want him to keep doing that. You know, many industries offer incentive-based compensation. Consultants can earn larger fees for hitting key milestones. You may have seen construction companies. They can get a bonus sometimes for completing those large projects ahead of deadlines. Well, historically, medicine hasn't worked that way. We often think of physicians being compensated for their time rather than the actual results that they provide. But value-based care aims to change all that. And today's guest is Christine Myers, a practicing physician who heads up Christine Meyer and Associates. That's in Exton, Pennsylvania, which is just a few hair-raising miles, a few start and stop miles on the Schuylkill Expressway from the Medtrics Center City, Philadelphia offices. With more than 20 physicians and multi-million-dollar payments for value-based care, Christine is a proven success in the VBC model, so much so that she also coaches others as a value-based care consultant. That's what we're here to talk about today, teaching others how to transform their practices. Christine Meyer, welcome to MedEdge.
Thank you so much for having me. I'm so excited to be here.
We are thrilled to have you. Now, you and I were talking just at the start of this. You've got a Phillies shirt on, big Phillies fan myself, as are everyone who works at the Medtrics offices in downtown Philly. But it's more than Phillies for you. As I take a look at your bio, med school at the Hahnemann University School of Medicine at Drexel, residency at Jefferson, you practice in Exton. Are you Philly through and through? Where were you born? Where'd you grow up? And just tell us a little bit how Philly became home.
Yeah, so I'm a little embarrassed to say I'm actually a Jersey girl through and through, born and raised in New Jersey. And so I actually grew up a Mets fan, which, good Lord, but that was like back in the Shea Stadium days, so that doesn't really count, right? But yeah, so since I went to college at Rutgers and then med school, obviously at Hahnemann, like you said, so I've been in the Philly area and the suburbs, for my entire adult life, basically. That's what I call home now.
Outstanding, wonderful. Now, we're going to be talking about value-based care here, but I want to capture, if we could, we always like to start whenever we have physicians, all of our listeners, or I shouldn't say all of them, but a lot of them are coming out of the UME, the GME space. So we like to talk about med school a little bit. So just talk to us about, we've had people on the show that they're like, I didn't realize I was going to get into medicine, and that's what I did. Some people, the light bulb goes off at age 8. When did you decide medicine was what I wanted to do for a career?
Age 4 for me. So I remember I have this very distinct memory. My aunt, who has been my mentor growing up, was in medical school in Egypt when I was visiting as a young child. And medical school there, it was, similar, I suppose, but those med students had to bring home human bones, preserved human bones, to study them. And I remember so distinctly her sitting on the floor in her bedroom on a rug, holding like a femur bone, the giant thigh bone.
Right,
and I was like next to her, and she let me touch it. And I just remember so distinctly at 4, like how that bone felt, like how smooth it was and the contours. And I think that was the moment I was just like, this is what I'm going to do. Never veered from that.
Wow. That 4, you might have set a personal record, here on this, that we've had them. Yeah, but 4 is really young. Now, one of the things that we also talk about, and this process has changed for some people over the years, but we always like to ask the question about specialty. So when it came time to choose your specialty, what was that choice like for you?
Again, no brainer. My aunt was an internist and, old school primary care doctor. I pretty much spent much of my young adult life in and out of college living with her. And so I watched what she did. She was a solo practitioner. She woke up every day. First thing she did was go to the hospitals. She would round on her hospital patients, go to the other hospital, round on her patients there. go to the office, work a full day in the office, sometimes go back to the hospital, come home, make dinner, and then start the cycle all over again. And she was just my hero, Yeah. And I just knew whatever it was she was doing, that's what I was going to do. Even through like med school, around doing rotations and things. And, I thought surgery was neat, but not that neat. I thought OBGYN was kind of interesting, but, it was always internal medicine for me.
That's awesome. That is awesome. And your passion for that certainly comes through. We're going to talk, I really want to talk about the transition from non-value-based care to value-based care. But before we do that, when you're talking to someone who's never heard about value-based care before, how do you describe it? What's the elevator pitch for value-based care?
So the first thing I'll say is nobody should call it value-based care. I hate that term. People assign the word value with like this negative connotation, like value implies cheap or not high quality. I think it really should be quality-based care, or results-based care or outcomes-based care. So for me, it's basically like what value-based care is: reimbursing physicians for the quality of care they provide their patients. That's what it is.
Got it.
And if you provide high quality care, you get high payments. If you provide low quality care, you get less high payments or no payments.
It's one of those things that quite frankly, as someone who's not a physician, I read about it and my immediate thought is, well, that makes all the sense in the world. And then immediately after that, I go, well, that's probably really hard to wire your office to actually do that.
Yeah.
So I'm super curious about, and we're going to talk a lot about how you've actually done that, how you've set up your practice to do value or value-based care. But walk me through the transition. I assume there were some years in there where you weren't doing it that way. So just walk me through your own personal transition of, this is how I did it for X years, and then along the way we just kind of moved in this direction. Walk me through that direction, that transition for you.
I was spit out of residency into a primary care practice that was 3 older male doctors and me. And, in that, I was with that practice for 4 years. And in that practice, basically, it was churn. Just see as many patients as possible, as quickly as possible, and go on to the next. And that's just what I kind of grew up with. That's what we did. And, that's how we were paid. And if I spent too much time with a patient or didn't see enough patients, like that was made very clear to me early on. So, that practice sort of planted the seed in my mind, like, I don't like this. This is not good medicine to me, but I didn't know any better. So then fast forward, I start my own practice. But again, we know what we know.
Right.
And so all of our payment contracts were based on see this patient, spend some time with them, do things to them, do a cardiogram, give them a vaccine, do a pulmonary function test, whatever it is, submit a bill for the things you did to them, and the insurance companies will pay you. So this idea of do more to patients, get paid more was very quickly reinforced. And, when you own a practice, you're operating a business, there's a bottom line. And so I found myself very much in that rut of, we got to see more, we got to do more, always with the eye of, I want to be a good doctor, but I also have a business to run. That's kind of like how it goes.
So that's how it's set up. And what I'm really curious about is, while that's going on, has value-based always been an option for somebody like you that just doesn't get explored? Or did the insurance companies say, you know what, let's do this a different way? What's the genesis of this?
Yeah, I think the original value-based care model was HMOs, the very vilified, you have to get a referral for everything. Your primary care doctor is your gatekeeper. But there were some really great nuggets in that model that I think got tossed aside because it didn't work very well. Patients didn't get the variety of care that they wanted. They didn't get the choices. Doctors felt very locked in. There was a lot of administrative burden. So there were some nuggets way back when, in the HMO eras. But for me, I would say true value-based care It's probably been in the last 10 to 12 years that we've really started to see contracts very much focused on that, where first it was incentives. You got fee for service, for your do stuff, see patients, get paid. But also, and by the way, if you do a couple of these things really well, you can get an incentive payment or a bonus payment. And then over time, those incentives have become more and more substantial and more important. And the fee for service dollars have kind of started to shrink a little bit. So it's been an evolution, I would say, over the last decade or so. So
it's a trend that the insurance companies are in favor of, and you've been able to sort of rewire your practice or wire your practice. When you do something like this, it obviously doesn't just affect you. You've got a large practice. You've got a large team. So what does that look like? Does it look like you sitting down with members of your team and saying, okay, we're going to emphasize things differently? How do you go about transitioning your practice to really go after the quality care?
Yeah, so I think the first thing that's really important is this mind shift, right? So most doctors, I will say, go into medicine because they want to do what's right for patients. They want to do a good job. They want to take care of people. They want to be agents of good, right? So in our brain, at least I know for sure in my brain, when I first started to dabble in value-based care, my thoughts were, I'm a really good doctor. I care about my patients. I know good medicine. Therefore, I'm going to be really good at value-based care. Because if you just do what's right, it all should follow. And that does not work like that. So what I learned really, really quickly is that no matter how good of a doctor you are and how much you understand the guidelines and good quality care and how much you care about your patients, value-based care work takes intention. And it takes workflows, and it takes processes. And it was definitely not a switch like, today we're fee for service, now we're value-based care. It was this slow evolution, and it started with me. And I would say to anyone who's, a physician leader, it starts at the top. That mind shift has to happen with the leadership in the practice. And then it's all about communication. And the nice thing about value-based care and success there is you don't have to learn new medicine. We just re-emphasize what we know works. Preventative care works. Access to care works. Communication works. These are not like, I need you to go take a course in value-based care. It's not that. It is, let's get back to the basics about what keeps people well and focus on that.
It's a change for physicians. Is it also, I'm guessing, is it also a change though for the administrators in your practice? Is the processing different? Is the paperwork different? I'm envisioning someone who's working in your billing offices, having to know two different systems. What's it like for them?
Oh yeah, for it to be successful too. That's such a great question. It is a practice-wide transformation. You cannot just transform your clinicians or your clinicians and your MAs. It's everyone from our receptionists to our front desk people, to our phone people, to our billing department. Everybody has to be bought into what value-based care is. And it's the only way to have success because the things we measure now are different. It used to be my billing manager would say, and this is such a gross oversimplification, but you saw 50 patients and you made, $100. Now it's, you saw 50 patients, 20 of them got their colorectal cancer screening, 5 of them got their mammograms, 3 of them were in the hospital, and here's what you actually made. So it turns the record keeping, if you will, so much more complex. And the things that we look at now are so much more important in terms of taking care of human beings than what the bottom line is. So yeah, absolutely. It's across the practice. Everybody has had kind of first a shift in mindset and then absolutely a shift in workflows.
You've spoken and written about this previously that like all new things, you stumbled a little bit coming out of the gate on it, and you talk about some of those early days. I'm curious, what was missing? What was it, the mind shift, or was it actually those workflows? Yeah. What were some of those stumbles like?
It was everything. So, first of all, I had, and I think a lot of doctors have, but maybe many won't admit it. Like I had this little arrogance about it. When I was first presented with my value-based care contract, they're like, here's a contract, sign this. And if you do a good job, you're going to get a lot more money. And I'm like, done, like whatever. And I signed that contract with zero intention to do anything different. My intention was just like, I'm going to take this money. I'm going to keep doing exactly what I'm doing, and it's going to work out amazingly. I honestly felt like, wow, what a windfall. These people are idiots. Like, seriously, going to give me all this money to do nothing different? But what a wake up call. And so, I remember that first year so clearly. At the end of that year, we were presented with our results, right? And they're like, so, unfortunately, you didn't earn any incentive in your preventative care work. And I was like, that's insane. That's wrong. Because, like 20% of your eligible patients actually got their colorectal cancer screening. I was like, absolutely not. There is a mistake in your record keeping. There is no way. We talk to our patients all the time about colorectal cancer screening. And I fought it for a while and then started to dig into the numbers. And what I learned that first year is that talking to our patients about what they need to do is not enough. It's like 1% of what we need to do to get them to do what they need to do, right? So, and the colorectal cancer screening is a very powerful example because it's one of the hardest things we have to convince our patients to do. And it's also one of the most important in terms of preventative care, right? So I explained this to someone recently. It's kind of like I have 3 kids who are grown. My youngest is 16 now, but it's like having the conversation about drugs and alcohol. Like you can't sit them down one time and say, drugs are bad, don't drink a lot, and say, I did that, now I'm done. It's like an ongoing conversation over and over and over again, reinforcing those concepts. And that's what it's like with convincing patients to get their preventative care, especially when it's something as invasive and scary as a colonoscopy. So what I learned was we were having one conversation, we were ticking a box, but there was no follow through. There was no closing that. There was no really digging into that patient. Well, I told you last time to get this done. Why didn't you? That follow through was what was missing. And until we figured that out, we did very badly.
Well, let me ask you this. One of the things, and one of the things that we love about doing this show is physicians are they're just tough people, and I love that. And so there's a part of me that says when you get those results at the end of the year and you didn't earn any of them, and I love that you're defensive. You're wrong. That the reports are wrong. Was there part of you that thought, well, this model just doesn't work. I'm just going to go back to doing it the other way, or what made you say, you know what? Even though we did lousy, we're going to double down on this. So just talk to me about that conversation.
Yeah, I mean, again, back to the colorectal cancer screening thing. My aunt that I was telling you about, my mentor, she actually was diagnosed with stage 3 colon cancer at 59. And, physicians, everybody knows this, we're the worst patients, right? So at 59, she hadn't gotten her first colonoscopy, and she was a doctor. She knew she should, but kept putting herself low on the priority list. So she got diagnosed with colon cancer. My best friend from grade school got diagnosed with colon cancer at 45. And so colon cancer was it was near and dear to me. And I just knew that people needed to get this screening test. So for me to say it's too hard or it doesn't work, that wasn't an answer. To me, seeing those results, after I got over that initial shock, it was well, I have to do better. Not just for dollars. I have to do better because of my aunt, because of Sean, because of all of these people who didn't need to die or didn't need to be sick from colon cancer. So it was really that, I understood on a very personal level how important it was.
Gotcha. And obviously it makes sense. You understand that very, very well. And of course, we can apply that to all the other areas where I've seen value-based care applied, whether that's type 2 diabetes or anything else. The model makes sense.
Exactly.
I'm curious, and let's just stay on this example because it's just a great example. So when you see your screening totals are down there, what's that look like from a practice perspective? Is it grabbing everyone in the room and saying, we're at 20%, we want to get to 80%. How do you troubleshoot that to say, okay, how do we push that delta? What did that look like for your team?
So first thing is we had to get a team, So that's the other thing is value-based care requires a very intentional building of a team. When we started, it was just me, and I would hope that my messaging every now and again would kind of trickle down and people would figure it out. that doesn't work either. We had to start having, very dedicated team leaders for very specific things. Like I have a person who's responsible for all of our colorectal cancer screening. And I have a person responsible for all of our mammograms. And I have a diabetes educator responsible for all of our diabetic patients. That team wasn't built overnight, but over years, we've established this leadership team that owns some aspect of our value-based care work and then translates the messaging to their departments, and so there's this trickle down of information that is so, so important. With the colorectal cancer screening, the first thing I did was just really look at what the barriers were. I started asking patients, why not? And sometimes it was fear. Sometimes it was, not understanding the importance. Sometimes it was the prep. Sometimes it was not being able to get a ride. So one of my first real aha moments of like, wow, I can do this. We can make value-based care work was this decision or this idea we had collectively as a team to host a colonoscopy event. So we called up our local GI practice and said, hey, will you do 30 colonoscopies on a Saturday? And they were like, okay. And then we just made it a mission for many months to recruit 30 patients who were delinquent in their colonoscopies to get a colonoscopy on a Saturday morning. And, it was a little bit of a struggle, but we're like, hey, you can't say you have to work. It's Saturday, right? You need a ride. There's people available on Saturdays. So it's not that. And then that was a little bit of a struggle. So then I upped the ante and I was like, listen, I'm 40 at the time. I'm 45 years old. I'm going to get my colonoscopy on this Saturday too. And so I just put it out there to my patients, like, come have your colonoscopy on Saturday, April, whatever, with me. And like, it was crazy. That schedule just filled up. And it was just such an amazing thing because we figured out that people need the nudge, right? People need to know that even doctors get colonoscopies. I did a video of myself going through the prep and, how atrocious it was even for me. And, just acknowledging it. Yeah, this isn't fun, but it's important. And I think between the event being on a Saturday, the messaging, my personal colonoscopy, the video that went viral after that, like all of those things, like all of a sudden within 2 years, our colon cancer screening rate went from 20% to like 88%. So it was these little layers of things, but now we have a culture in our practice of you need to get your colorectal cancer screening. We have messaging that's just on point. We have that, repeated conversations because everybody has bought into how important it is.
Let me ask you this question. Everything you're saying makes total sense that you needed to bring in these additional layers of support. When you're speaking to physicians and I'm hearing in this value-based care story, I'm hearing two themes. The first is it's better for patients, and I think that's a no-brainer. Your previous anecdote it just shows that. The second piece is you acknowledge that you were drawn to value-based care because of increased compensation. However, you also underestimated some of the other overhead that you had to bring in. So now when you're talking to people about value-based care, and this is just a pure economic question, do you still believe it's a more profitable way to build your practice? And how has your opinion changed?
Absolutely. But I think there's one like fundamental concept that I think is missed a lot. And I missed it at first. It is when you earn those first value-based care dollars, immediately, the first thing you have to do is reinvest them into your value-based care team, so
it's not a bonus, right?
It's not a bonus. It's not a windfall, because you get these big checks. Like I remember the first check we got was like $35,000. And, I was like, wow, I want to go to Italy. But then very quickly you realize like, that's the way to like fizzle out that success very quickly. So, by taking succeeding at the low-hanging fruit, get the easy value-based care dollars first, and then be super intentional about what you do with that money. I think it's okay to distribute it, as, a job well done, share that money, at least a portion of it, but then you have to continually build your team to continue to succeed, because the low-hanging fruit, you pick that very quickly. And then the next thing is a lot harder and requires a lot more manpower. And if you don't have that team in place, you're done,
Right. I'm curious, whenever we talk about emerging models like this, it's difficult to find people that you can work with or that can empathize or sympathize with what you're going through. You have a little bit of a heads up in that you're married to a physician. How is that informed? And I don't know this for a fact whether your husband does value-based care or not. Just how is that informed your practice, his practice, just sort of your growth as a couple and as business?
Yeah, so he is a pediatrician, and value-based care basically does not exist in the world of pediatrics because they're dealing with an inherently very healthy population. So they do have some incentive dollars they earn for like their vaccination rates and their rates of getting kids to get their physicals, and they do target that. And he's learned, some of my workflows on a much, much simpler level. Like, he had the same thing. He was like, of course our patients all get their vaccines. And then they got their reports and they're like, no, they don't. And they figured out quickly that, they have to actually call people and be like, hey, you missed your physical. You need to come in and get your vaccines. And so I think that has kind of helped him. I think for me, the really neat thing about being married to a pediatrician and one of our offices is shared space is the convenience of it makes it almost like a family practice, right? So the parents come to us and the kids go to him. And so we have this, we know the history across the generations, and that's so helpful. Like I can say to my husband, we have this family together, and the 35-year-old mom has colon cancer, and you're taking care of the 17-year-old kid. Like, this is an important piece of the history that we have to be connected on. And that's pretty unusual. And then, we try to run our practice in a very similar way. So the messaging is very similar. The access is very similar. And I think that just reinforces all of the positives about value-based care, even if it's not quite as relevant to his practice.
One of the things that I just really enjoyed, after learning a little bit about value-based care, and then I looked at your website, there's two features, I'm going to call them features of your practice, that as a patient, I would really love. The first is I literally can text your office if I have a question. The second is the idea of walk-in clinic hours, so that I can get seen even if I don't have an appointment for existing patients. And what's interesting is I really love those features as a patient, as a customer. But now speaking to you, I'm sort of a light bulb's going off in my head. Oh, she wants me to go to the doctor sooner so that I have better results.
Exactly.
And one of the things that I often think we always talk about is, are incentives aligned? And so one of the things that I really am impressed with value-based care is it feels like the incentives are really aligned here, right? This SMS, this walk-in clinic, those to me just seem like those are things that you're doing that your patients love, but they're also things that really should help your bottom line as it relates to reimbursement, right?
Absolutely. But to be clear, those two things that you mentioned, they came about, again, as a result of colossal failures, as a result of angry patients, terrible Google reviews. There was a running theme. Like for example, I can't ever get anybody on the phone, and if you talk to any primary care practice anywhere in the world, they struggle with their phones. There's never enough people. There's never enough lines. There's always too many calls. And so we were like, how can we offload we can't just keep hiring more and more people to answer the phone. We upgraded our phone system like 3 times in 2 years because we're like, it's the phone system. No, it's not. It's that, it's just not feasible to answer as many calls as we needed to. And so I was like, what do I like to do? I hate talking on the phone. If I can do something online or text, I'm going to do it. And so that's where the texting platform came from. And it's been so tremendously popular for exactly what you said. patients can get through, they can get an answer immediately. And a lot of times, the text does turn into a phone call, but it offloads so much pressure on the team. The patient feels like they're not waiting on hold. Like, it's just a great thing. The walk-in, same thing. So for us, we figured out that our patients were going to urgent care a lot. And why are they going to urgent care? Well, because they don't want to wait to get an appointment. And even though our office is open 7 days a week, which is no accident either, it was, people don't want to wait an hour. They want to come when they want to come. And so, adding that layer improved patient satisfaction first. And then second, reduced our patients' trips to urgent care and to the emergency room, which has been, is critical for success in value-based care.
One of the things that I found really unique about that on your website, which I know I've never seen on another physician website, and it was that when you came out with the walk-in clinic, you flat out on your website said, this is a pilot. We're going to try this. That felt so honest and so refreshing, because when I think of how healthcare tends to work, I could imagine some practices debating, should we do this for months or longer? And then they would do it. And then that's kind of the new normal, whether or not it works out. You kind of went out, we're going to try this. It's a pilot. And so the first thing I want to ask you about is that idea to give yourself permission to experiment. That feels a little unique to me. How do you make the decision to say, we're going to do that, but we're going to tell people it's a pilot?
Yeah. So that's not me. That's my team. So for me, my attitude is failure is not an option. If we're going to do it, we're going to do it. We're going to do it forever, and we're going to do it more and more and more. That's my attitude. And that does not work all the time. So thankfully, I have my cabinet who really bring me down, and they're like, here. So this is me, let's do it. Let's do walk-in. And I remember it clearly. I'm like, let's do it the Tuesday after Labor Day. And they're like, oh my God. And I was like, and let's put it everywhere. Let's do it for all day. And they were like, whoa, whoa, whoa. And these people on my team have been with me 20 years. So they understand how my brain works. And they were like, okay, Christine, here are all of the reasons why we can't do that. And they just presented me with a very logical explanation of all the things that could go wrong. And so announcing it as a pilot to our patients, like you said, gave us permission to pull back and say it doesn't work. But it also, and this really helped, our patients gave us grace. When they walked into our office for our first walk-ins and they waited for 2 hours, they were like, okay, I knew coming in, this was a pilot. I knew this wasn't going to be smooth right out the door. And over time, we've just used that permission to continually improve and expand those walk-in hours.
It sounds like you and your staff just have a wonderful relationship. And I can envision similar conversations that the opening your office up to SMS. Was it similar of, okay, we get the value, but you know what this is going to do, right?
And it's so funny that you asked me that, because we had that conversation for 18 months. And my practice manager, Claire, and I kept saying, we need our patients to text. We need our patients to text. And she was like, we're not ready. We're not ready. And the beautiful thing about our yin and yang is I'm the idea person. I'm like, we can do it. We can do it. Right. She's the practical side. And she was like, we need more people to be on the texting platform. We need to understand it. We need to make sure it's HIPAA compliant. We need to make sure that there's clear, automated responses. So all of that infrastructure had to get built despite my readiness, right? So it took a year, but I think it's two things. We could have spent 5 years building the infrastructure and never done it. So, I kept saying what's our MVP? What's our minimal viable product? Let's put that out there. It's not going to be perfect. It's going to be okay. And then we're going to continue to improve upon it. And that's really how it happens. And that happens with so many initiatives in our practice, new things that, I'm ready to push out there yesterday. And my team's like, whoa, let's get it right first.
when you talk about minimum viable product, so that's obviously a term we use in software development. And whenever we talk about business, I always think through the lens of people, process, and tools. And in this scenario, it seems like for VBC, you really had to have all three of those buttoned up, which makes me wonder when you are a VBC consultant now, teaching other physicians to get where you are without going through maybe some of those pains that you went through. What are some of the big reasons for pushback, and what are the reasons you see for physicians not wanting to go down this road?
Yeah. First of all, doctors, like a lot of people, don't like change. They resist change. Two, doctors, and I'm including myself and my husband in this, are notoriously extremely frugal. Doctors don't like to spend money. Doctors like to make money. But that piece of you can't just make the money, you have to reinvest the money is really hard to get doctors to swallow. And for some, they need to invest dollars before they make any dollars. They're not even going to get that first check if they don't do something now. So those are some of the hardest things. And I think the other piece of it is, when you talked about processes, we don't stop at least in primary care, to evaluate our processes. We wake up, we go in the office, we do the same thing, and we just keep doing it and doing it and doing it. We don't pause, because you can't pause, because sickness doesn't pause, patients don't pause, to say, what is our process? Do we even have a process? Is it working? Where are there holes? So it takes someone, and I had to step back from some of my patient care to be the person, be that lens to say, what are we missing here? And that's a hard thing for doctors to do. But that's my job, to show them this is what you need to do, and I can help you do it. But it's not going to be easy, and it's not going to feel good at first. Absolutely.
As we think about it, this is interesting. This has been such a fun conversation. So much of it has been about, however, the business of healthcare, which is interesting because a lot of the people that watch or listen to this show, they're in undergraduate medical education or graduate medical education. And oftentimes there is a disconnect between training somebody to be a physician and training someone to actually run a physician's office. What are in your interactions with medical schools or medical students? How can we as an industry, medical education, how can we do a better job of promoting value-based care?
I think that's so important. When I was in med school and training, we got exactly 0 minutes of education in the business aspect of medicine. In fact, our primary care experience was in a free clinic in Philadelphia where, we'd spend an hour and a half with each patient because there was no patients, and we were residents. We weren't getting paid. So that's kind of what you come out of training with, at least in my day. I think that students in training, especially if we want primary care to stay viable, and I firmly believe that independence is what will keep primary care viable, not being corporate owned, not being private equity owned, not being hospital owned. So we need to incorporate in our education, show them the positives, show them the autonomy, show them the other piece of your brain that you get to engage when you run a business. Most medical students are multifaceted, really intelligent. Mm-hmm. And, I am so stimulated by the business aspect. I love the medicine. I love the care. But, opening their eyes to the other pieces of their brain that they can use would be tremendously helpful. And then there's some basics, like here's what it costs. Here's what you need to expect. Here's how much money you are not going to make out of the gate. All of those things would be so helpful.
One of the things that, as we come up towards the end of the program here, I am very convinced that if you and I were to speak 5 years from now, you and I are still going to be talking about value-based. I think you have embraced it. I think your staff has embraced it. I think the benefits are there. But I am curious, what do the trends show you? Do you think 5 years from now we're going to see a lot more value-based care? Do you feel like it's going to be a fringe model? How do you see it changing over the next handful of years?
I think it's definitely going to become more and more relevant. But, this is interesting, and this may surprise you, Marcus. Like right now, only about 25 to 30% of my practice revenue is from value-based care, we're still operating at a 70% fee-for-service model. So, and it's been 10 years. So it's a really slow evolution. I don't think there's ever going to be a world of all value-based care. But what I would love to see is, 50-50, 60-40, something like that, where, over time, the push to quality becomes much more important from a bottom line standpoint, because here's what happens. We don't just take good care of our patients that are in a value-based care contract, right? We've established these workflows. And even though only 25% of our revenue comes from those contracts, that work translates across the practice and elevates the care all of our patients get. So we may get 25% of our revenue from VBC, right? But we get 100% of our patients get care based on the VBC model, which is what you want.
I'm really glad you said that, because, one of the things that I was thinking about was these SMS capabilities, right? As a patient, I don't necessarily know whether you're getting reimbursed for VBC or not. But as a patient of your practice, I still get to take advantage of that.
You're benefiting. Yep, exactly.
We are sadly out of time. Christine, I could do this for a very long time. This has been a lot of fun. I always like to toss people a few random questions at the end, and you're wearing that shirt. So I'm going to ask you, I got two questions for you. Who's your favorite fight and Phil right now? Who are you really enjoying watching?
Well, after last night, Bryson Stott, hello, he came out of the gate, and he's so humble and great. And of course, Alec Boehm, taking it on the knuckles and just moving on.
And my second question for you is, it's tough to pick a top pitcher right now, but if you got to put somebody on the hill right now, who are you going with?
Oh, come on, Ranger, all the way.
Unbelievable. The guy, and I'll tell you what, I can't decide what I enjoy more, the fact that he's not giving up any runs, or the fact that he just looks so cool while he's doing it. He's just
have you watched him field his position? It's like he's playing catch in his backyard. He's like, yeah, maybe I'll toss this to first. Wait a minute or two. It's just beautiful to watch.
Yeah.
I love it.
It sure is. Christine, I assume if people have other questions for you, best place to reach you is at ChristineMeyerMD.com. Is that correct?
In terms of the consulting, emailing me, Christine at ChristineMeyerMD.com. And then I have my consulting website is cmmdconsulting.com.
Wonderful. Outstanding. Christine Meyer, thank you so much for joining us today.
Thank you so much. What a pleasure, Marcus. Thanks.
You got it. I'm going to take it out here. As we've said before, for better or worse, healthcare is, in fact, a business. And at its heart, business consists of the trading of resources. Historically, physicians have been compensated for their time. Value-based care, on the other hand, looks directly to the results achieved through healthcare as a proxy to determine how, in fact, a practice should be compensated. Before today, my opinion on value-based compensation is that it sounds perfect in theory, but how do we really implement it? Well, I think we learned a lot today from Christine. So much thank you to Christine Meyer of Christine Meyer and Associates. She's made that work her passion. You've been watching MedEdge. MedEdge is brought to you by Medtrics, which is the premier engagement platform for medical students, residents, faculty, and administration of both UME and GME. Learn more at medtricslab.com. For Santosh Cherian and everyone else on the MedEdge team, I'm Marcus Grimm.